Hi, everyone. I would like to welcome you. My name is Laura Hunt, and I am the program coordinator at the Madison Senior Center. This presentation is put on by the Madison Senior Center and the Monona Terrace and is part of their wellness series. The Senior Center is committed to healthy aging opportunities for all older adults in the Madison community. The sponsor of today's program is the UW-Madison's All of Us Research Program. All of Us is working to make medical research reflective of all people, including BIPOC and older adults. Please visit their website at allofus.wisc.edu to learn more. Today, we welcome Jonathan Temte, MD and PhD, who is an Associate Dean for Public Health and Community Engagement at the University of Wisconsin School of Medicine and Public Health, where he also serves as a professor of family medicine and community health. Dr. Temte served on the U.S. Advisory Committee on Immunization Practices from 2008 until 2015. He currently chairs the Wisconsin Council on Immunization Practices, is a member of the CDC's Board of Scientific Counselors, and is the American Academy of Family Physicians representative on the Advisory Committee on Immunization Practices COVID-19 Vaccine Work Group. At the end of Dr. Temte's presentation, we will offer Q&A. Webinar attendees can participate by clicking the Q&A icon on your screen and typing in the text box that appears. Please feel free to type in your questions anytime during the conversation, or during the presentation. Following this presentation, a copy of this webinar and any handouts will be posted on the Wellness Talks page of Monona Terrace's website. A survey will be distributed within a week of the program. Your feedback is important to us. And now let us turn our attention to Dr. Temte. Thank you.
Well, thank you so very much, Laura, for the introduction. It's a pleasure to join in with everybody today. And we're going to talk about shingles and what you should know. I have been clinically active in family medicine for now over 29 years and in residency before that. And shingles is something that we deal with all the time. I have to just relate one story from years ago of a woman who was hospitalized with shingles and was over her scalp. And she described the feeling as wearing a swim cap that was far too tight and she could never get it off. Well, with that in background, I just want to spend the next few minutes talking about shingles. We're going to give an overview of shingles viral disease, talk about the recognition and treatment, think about some of the risk factors for shingles, and how we can prevent this relatively terrible disease with a simple vaccine. Well, shingles is part of this whole complex known as herpes zoster, and is caused by the varicella zoster virus. Oftentimes we just abbreviate that as VZV. And this is the same virus that causes chickenpox. Now, in my generation, everybody had chickenpox as a child. I was a holdout. I didn't have it until I was 17. And I think at one point in that episode, I had over 1,000 lesions across my skin. It's pretty terrible. But chickenpox used to be a very, very common childhood illness. And because we have a vaccine for chickenpox, it's become very rare. I work and teach in a family medical clinic on South Park Street here in Madison. And I always used to be able to find cases of chickenpox to show the residents that who I'm teaching. And I really think it's been somewhere between 10 and 15 years since we last saw a case of chickenpox. So the vaccine for chickenpox has been very, very effective. Well, once you become infected with chickenpox, you can have reactivation of this virus. And the reactivation is what causes chickenpox. So let me just give you a diagram here, and hopefully you can see my pointer. If we start out here with chickenpox lesions, these will erupt on the skin, and the viruses will follow the nerve endings all the way down and end up very close to the spinal cord in this place called the dorsal root ganglion. And these viruses can stay there and be alive, be able to reemerge for decades. And for reasons we don't quite understand, occasionally they will wake up and they will follow that neuron all the way to the surface again, and you end up with the zoster lesions or the chickenpox lesions, or the shingles lesions. So the symptoms of shingles is this burning, throbbing, or stabbing pain that can occur days to even sometimes weeks before the rash appears. Usually it's a matter of days, however. The rash is painful, and what we call in medical practice a macular papular vesicular rash. What this means is it starts out as a spot, those are maculars. Papular means it gets a little bit of surface to it, it pokes out a little bit, and then it turns into a blister or the vesicular rash. And these occur along the nerve pathways on the surface of our body. They're almost always on one side or the other, on your face or trunk. And the vesicles typically dry up and heal over the course of 2 to 4 weeks. During those 2 to 4 weeks, though, it can be very, very painful. And it can be accompanied by things like fever, headache, pain when bright light hurts the eyes, and sometimes nausea. And in this picture up in the corner, you can see a typical rash extending over someone's trunk. Now, when we talk about them emerging onto nerve pathways, it's worthwhile just to consider how the skin and the sensation in skin is related to the various nerves in your body. And we call these dermatomes. And if we take a look, for example, around the belly button is the thoracic nerve number 10. And it's a band that basically encircles at about the waist level. If we take a look at the head, there are various areas that nerves come out. So this area called V1, V2, and V3 are 3 branches of the trigeminal nerve that go over the face. You can see the first cervical nerve going over the back of the head, and so on. But this becomes very, very important when we start seeing the lesions. So for example, this right here is a thoracic level lesion, probably thoracic level 8 or 9. Here's one in the cervical or the neck region, probably the 3rd cervical nerve. And here's a close-up of how that rash looks. It's red, it's bumpy, and it has these little blisters to it. Well, complications. If the rash isn't bad enough by itself, the most common complication is something called post-herpetic neuralgia. That means after the herpes infection, and neuralgia is nerve pain. So this is the most common complication, and it can be mild to severe in areas where the shingles occurred. The pain can be constant, it can come and go, but of real importance here, this pain can keep going for weeks, months, or even years. People have described the pain to be as bad or worse than childbirth. And the pain, as you can imagine, being unrelenting, can cause problems with sleep, with mood, work disruption, impairment of activities of daily living, and also really important, this can lead to social withdrawal and mental depression. The risk factors for post-herpetic neuralgia include being older, over the age of 50, having severe pain at any time in the course, having a more extensive rash, and occurring on the face. So again, if you remember me talking about the trigeminal area, it can occur up there. And as you can see in this gentleman, this is a trigeminal zoster infection or trigeminal shingles on the face. Other complications. If this tracks out with the eye, you can have what's called herpes zoster ophthalmicus. And this is just reactivation of the shingles involving the eye and represents about 15% of shingles cases. Untreated, it can cause vision loss and blindness. There can be other neurological complications, so inflammation of the spinal cord called myelitis. There can be inflammation of the brain, encephalitis or meningoencephalitis, ventriculitis. There can be effects on the nerves that cause or that help keep your eyes looking together. So you can have double vision from these cranial nerve palsies. And there can even be stroke syndromes with this. In some cases, we can see this virus not only showing up on that one area of the skin, but it could also become disseminated throughout the body and cause a rash that looks like chickenpox. There can be pneumonias, lung infection, hepatitis, which is liver inflammation. There can be severe bleeding disorders. And then if you can imagine a big open area of skin, we worry about secondary bacterial infections of the skin, and there can be permanent scarring and changes in pigmentation. So, who is at risk of getting shingles? Well, it turns out that over the course of our lifetime, almost 1 out of every 3 people in the United States will come down with shingles. We estimate that there are 1 million cases each year in the United States. And anyone who has ever had the chickenpox or the chickenpox vaccine can develop shingles. It does look, however, that the use of the chickenpox vaccine has been helpful in reducing the number of cases. Who's at higher risk of shingles? Well, one of the biggest factors is age. The older we get, the more likely we're going to come down with an episode of shingles. I have a question mark after stress. We used to think that psychological stress could promote the appearance of shingles. There have now been some very, very good studies looking at this. And one of the biggest looked at individuals who had recently undergone a very stressful period. And the stressful period was defined as the loss of a partner. So for example, having a husband or a wife die, or having a spouse spend time in an intensive care unit. They found that when compared to people who weren't going through these stressful events, there was no difference in the occurrence of shingles in the weeks following. We do know that many medical conditions can lead toward shingles, cancers, HIV, or after bone marrow or solid organ transplantation. With all these conditions, we're looking at suppression of the immune system. And if we can think of the immune system as holding those viruses in check, things that make us less immune can trigger off shingles. So for example, steroid medications, common one we use is prednisone. Chemotherapeutic agents, typically for cancers, or medications we use following transplant or with connective tissue disease related medications. When we talk about age, this is a graphic that just shows how age relates to not only shingles or zoster shown in the light blue, but also in the development of that post-herpetic neuralgia. So the biggest factor out there when it's looked at independently is going to be age. I also want to point out here that there really is a big step off between age 40 and age 50 when the rates start coming up more significantly. So just a visit to my own department. A few years ago, we pulled data from our data system to look at shingles specifically. This got started with a request from one of my partners, and I was interested, so went ahead and did this. So if you take a look, this is over our department's entirety over a number of years looking at cases of shingles. And it turns out that you see most of the cases gathered in the middle years dropping off as people get older. But that isn't the whole story, because what you have to do is adjust to the number of people at various age groups. But a couple of things to point out here early on is we see more women than men for shingles. Does that mean that being female is a risk factor? No, it means that women are better about coming into the doctor than our men. The other thing to point out is even though we tend to think of shingles as a syndrome or a disease of older age, we actually see it all the way down into children. And we can see this at any age. But as I mentioned, it's important not only to consider who gets it, but what the size of the population at various ages. So when we adjust on over, and we can say, well, how many cases did we see versus how many did we expect in that age range? It turns out we expected a few in infants and we didn't see any. And age 2 to 4, we see a few cases, but we expect a lot more. But once we get into the age after 50, we start seeing the number of cases that we observe exceeding what we would expect on the population of that size, and even more so at age 65. So putting this a different way, we can kind of look at age groups and do we see a deficit of shingles or do we see an excess? And as it turns out that below the age of 50, we see fewer cases than we would expect by chance. And over the age of 50, we see a lot more cases than we would expect by chance. So not only do the big studies show that, but when we look at our own data locally, we see the same thing. The other question is whether or not shingles appears to occur seasonally. And as it turns out, we couldn't find any seasonality whatsoever. We see cases occur throughout the year. Well, let's talk a little bit about treatment. Shingles can be treated. There are antiviral medications we use. Their names are acyclovir, valacyclovir, famciclovir. And these are good and safe medications. They will shorten the length and severity of shingles, but they're most effective if they're started as soon as possible after the rash appears. If you think you have shingles, contact your healthcare provider as soon as possible. And as a healthcare provider, I do not mind if someone calls up and say they think they have shingles. It turns out to be something else. But this is one of these things that I consider a medical urgency, if not emergency, because if we can get medication started early, we can change the course of this disease, and we'll change the course to the far better. We have a number of pain medications that can help. Usually they can be over the counter, things like Tylenol or ibuprofen, or some prescription medications when the pain is really severe. The itching from the rash can be relieved by wet compresses, calamine lotion, or taking a colloidal oatmeal bath. This is just a lukewarm bath mixed with ground up oatmeal that can be very soothing. Well, even though we have good treatments for shingles, the real challenge is getting in to see a doctor, a nurse practitioner, a physician assistant in time enough to get things started. And really, this is just a matter of 2 or 3 days that we have to get these started. A much, much better option is prevention. And to prevent these, we're looking at vaccines. There are 2 vaccines in the United States that are licensed for use for shingles. Zostavax is the older one, and even though it's still licensed, it's no longer available. It was a live virus. It was attenuated, meaning that it doesn't cause illness, and was a single dose. It turns out that this vaccine was exactly the same vaccine that we give to infants or toddlers, at 12 to 18 months, and again at 4 to 6 years. Exact same vaccine, except it had about 14 times more virus in it than the childhood version. The other vaccine is called Shingrix, and it's now preferred. And because this body, the Advisory Committee on Immunization Practices, made the recommendation and stated that they preferred this vaccine to the Zostavax, the market dropped very quickly for Zostavax, and the manufacturer stopped providing it. The Shingrix vaccine is what we call a recombinant vaccine. This is one where it's not live, it's just part of the virus that is made in cell culture and injected. And it's injected with an adjuvant or a chemical that really helps prime the immune system to response. This is a vaccine we give in 2 doses, 1 dose and then the second dose 2 to 6 months later. So Shingrix is, and I have to tell you, I usually don't use brand names for vaccines, but here's one where these 2 vaccines are very, very different. So that's why I'm using the brand name. The Shingrix is recommended for herpes zoster, for prevention of post-herpetic neuralgia, and for prevention of complications. And this is meant for anybody who has a normal immune system, age 50 and older. This is for anybody who had previously received the Zostavax. So if you received the Zostavax already, get the Shingrix. And it's also approved for anybody who is immunocompromised as long as you're over the age of 18 years. The reason that Shingrix is preferred is the effectiveness or the ability to prevent illness is significantly higher, and it does not tend to lose its protection as fast as Zostavax did. To show you very quickly here, that this is from studies that came out, after Zostavax, the live attenuated vaccine, came. And if we followed over time, it started out preventing about 2/3 of infections, but after 8 years, it dropped down, so it was no better than not getting the vaccine. So this vaccine waned over about 8 years' time. As it turns out, the Shingrix vaccine has a much higher rate of protection. So for individuals aged 50 to 59, we see, at least in the first year, about a 97% benefit. And even a little bit higher in 60 to 69, and it just drops down slightly at age 70 plus years. But even at 70 plus years, we see over 90% of people protected. I just put the blue dots up here to show the initial benefit of Zostavax at age 60 to 69 and at 70 plus. So the Shingrix vaccine has been much more effective for preventing shingles. Well, what are the side effects? I'll just mention them for Zostavax really quickly. Being a live virus vaccine, you could get a rash. If you happen to give it to somebody who was immunocompromised, it could lead to life-threatening or fatal complications. And sometimes this vaccine led to a shingles outbreak. These were very, very rare, though. With Shingrix, on the other hand, the common things are a sore arm at the injection site with mild or moderate pain, redness and swelling. 1 out of every 6 people have side effects that prevent them from doing their regular activities for 2 or 3 days. Side effects, on the plus side, are more common in younger people. And, people can have it with one or the other or both doses. I have to confess, my wife got this in the last year, got her first dose, and she had a pretty hard day or two of side effects. Nothing significant, but sore, felt tired, felt achy for probably 2 days after receiving that. Okay, a couple of words here on insurance coverage. So Medicare, which many of you are familiar with, there are 2 parts. There is the Part D and Part B. And traditionally, under Medicare, the shingles vaccine was covered under Part D, but that really meant that you were facing a bit of a risk there because there could be a large co-payment for the recipient, depending on the plan. Shingrix or shingles vaccine has not traditionally been covered under Part B. Part B covers things like your annual influenza vaccine, where it's entirely covered. It covers the pneumococcal or pneumonia vaccine completely, but has had traditionally not covered the shingles vaccine. On Medicaid, it may or may not be covered depending on the plan and depending on the state. And if you're covered by private insurance, Shingrix is covered as part of the Affordable Care Act with no deductible. The Affordable Care Act requires insurers to cover any routinely recommended vaccine by CDC and the Advisory Committee on Immunization Practices. Well, the good news out there is with the Inflation Reduction Act of 2022 that was just signed a couple of months ago, that all ACIP recommended vaccines for seniors are now covered under Medicare Part B. So probably starting in January, Shingrix will be covered for any Medicare recipient without copay. I'm going to just take you to our current recommendations for vaccines. And this is all the vaccines that are currently recommended for adults. And we have the things in yellow that are recommended for everybody. And I'm just going to show you here that here are our 2 doses of shingles vaccine. In the purple are for some people in the age range from 19 to 49. Those are people with immunocompromising conditions. And then 2 doses are routinely recommended for everybody from age 50 and above. Likewise, I'm just going to point out, I would be remiss here in October not to remind you to get a flu shot. We recommend this routinely for everybody from age 6 months without a top end. Last little thing I want to kind of mention here is our Wisconsin immunization registry. Wisconsin has the best immunization registry in the country, and it's been around for a long time. And if you've never used, this is a wonderful tool that you can use to not only check what vaccines you have received, but which vaccines that you might be in need of. And so if you just go on the internet and Google WIR, I can assure you the first thing that pops up is the Wisconsin Immunization Registry. When you get to that page, it'll look something like this. And at the bottom, there's a button here that says look up vaccine record within WIR. And if you click on that button, it'll take you to a screen like this where you put in your name, first name, last name, birth date, and either a social security number, a Medicaid ID, a healthcare member ID, any of those work. And what it does is brings up your vaccine history. So for example, here's vaccine history for COVID-19 vaccines. And it's the reminder of what are recommended. So here it says hepatitis A is recommended now, MMR recommended now, and here's zoster recommended now. So that's just the reminder system out there for all of us to get our required vaccines. So I'm going to finish up here and just with a summary here that shingles is common, it is painful, and the risk of shingles increases with age. Second, if you suspect you or a loved one may have shingles, call your healthcare provider as soon as possible. Early treatment with antiviral medications can truly help this. The best approach, however, is prevention with a safe and effective vaccine. And when you're thinking about that, don't forget your COVID-19 vaccines and boosters, the influenza vaccine, and just the reminder for anyone over 65 years this year, ACIP, the Advisory Committee on Immunization Practices, is recommending a high dose or an enhanced vaccine. So with that, I will stop and see if there are any questions out there. Thank you for your attention, and keep healthy.
We do have a number of questions out here. They've been slowly coming in. And one that keeps reoccurring is if somebody has had the shingles but not been vaccinated, should they still get vaccinated? And then with that, if you get it, can you get it again?
Yeah, 2 very good questions. Number one, if you've had shingles, you can certainly get it again. And the question often comes up, when should I get a shingles vaccine if I've already had shingles? And according to the official recommendation, there's really no time delay between vaccine. On the other hand, if you've had a case of shingles, your immune system is really pretty well primed. So normally I tell people that if you've had a case of shingles, go ahead and wait for about a year and then get vaccinated. Number 2, can you get this over? Yeah, unfortunately, people can get this over multiple times in their lives. Usually we see a period of time between cases. The other interesting thing is occasionally I've dealt with individuals where their family tends to be prone to getting shingles. So I've had individuals who not only had shingles, but they relate that their brother and sister and parents have had shingles as well. So this tends to run in families, but we don't understand the genetics behind that.
Okay, would corticosteroids for allergies, rashes, asthma applied via an ointment or inhaler nasal spray increase the risk?
No, I think we have to have a differentiation between the steroids that we use on our skin, in our nose, inhaled, versus what we take as a pill form or an injection. When we use a nasal spray or an inhaler for asthma, or we put a steroid cream on our skin, our whole body absorbs just a very, very small dose, and it doesn't have an effect on immunosuppression. So for example, if you've been a religious user of a nasal spray for your allergies for years and years and years and suddenly stop, we don't worry about the effect of that because it has never interacted with your immune system. On the other hand, for people who are taking prednisone, this, especially if you're taking a higher amount in the order of, let's say, 15 to 20 milligrams a day or higher, if you suddenly stop that, you've really suppressed your immune system and it doesn't kick in very well when you stop it. So you have to be careful with that. But so there's a real differentiation between, the inhaled or the topical and the injectable or oral steroids. And if you have a question about that, you ask your medical provider. They can give you a pretty good answer.
Does exposure of shingles lesions to UV light have any effect toward reduction?
Not that I've ever heard. By the time they have erupted, the damage is already done to the skin. And so by the time they're erupting, you're just really dealing with the after effects of the infection. But that leads me to a different line here, is if you have a shingles infection, you are able from that infection to transmit to somebody else. And so we recommend people who have shingles to avoid interactions, particularly with young children who may not have been vaccinated for chickenpox yet. You want to avoid close interaction with people who are immunocompromised. And if you have to be around somebody, for example, if you're a caretaker for a spouse or loved one, you have shingles, just make sure the entire area is covered with an occlusive dressing so you don't have that exposure.
We have a few questions here about, and I think you might have touched on this. Does Shingrix decline in efficacy over time? Is it recommended to get a booster after a certain number of years?
That is always a wonderful question with vaccines. And the bottom line is Shingrix has not been out there for a real long time. I think I have to go back, but it's been 5 or 6 years. We have not seen it decline as quickly as Zostavax, but the bottom line is the benefit from vaccines almost always declines over time, with a few exceptions. And the question then becomes, well, at what point do they decline enough for us to think about a booster? The good news is with Shingrix is we haven't seen it decline very much at all in the first few people who have received this vaccine. And I always tell people with a vaccine that's been around for, a few years, keep tuned. And the job of CDC and the Advisory Committee on Immunization Practices is to monitor that and adapt the recommendations as we need be. But right now, we're approaching this as 2 injections and you're done.
What triggers the shingle virus to reactivate? What is the insight on any probability for reoccurrence?
Yeah, that's the really important question here, and we simply don't know. Um, at one time, as I mentioned earlier, that we thought, situational stress could do it. That doesn't. We do know, however, that big hits on the immune system, so chemotherapeutic drugs uh, can lead to reactivation. Uh, Immunosuppressive drugs can do that. And so that one of the take-home points is, if someone is looking at the possibility of going into, chemotherapy for a cancer, for uh, lymphoma, things like that, talking to the oncologist, the hematologist about if you're not vaccinated, if it's appropriate to get vaccinated at this time before you get started. Again, the best way approach is to get vaccinated before you need to, when you're feeling well. So my plug, this is a great preventive tool.
Is it possible to take Shingrix or get the Shingrix vaccine at the same time as the COVID vaccine?
Yeah, absolutely. That the COVID vaccine can be given with influenza vaccine, can be given with the shingles vaccine. My sister just talked to this weekend, and she had received her high dose influenza vaccine and COVID bivalent booster on the same day. Didn't have much side effect. I will, if you're somebody who tends to respond vigorously to the COVID vaccine, I might put shingles vaccine and COVID booster on different days. And the only reason is some people respond, if you respond vigorously to the to the COVID-19, you might feel under the weather for a day or two if you get them both. But they're considered to be both safe in terms of no big time safety issues, and they're both going to be effective if you give them at the same time.
Right. If someone is not aware of having had chickenpox as a youngster, should they still get the shingles vaccine?
Yeah, absolutely. The older you are, when you get your first case of chickenpox, the more vigorous it tends to be. We have a lot of people out there who will swear they never had chickenpox, but if we check a blood level of antibody to the varicella, they'll be positive, meaning that they have seen this. So the take home is, if you don't ever recall having chickenpox, but if you were born before 1955, the likelihood is almost 100% that you've had chickenpox. And in fact, if you're born before the early 1990s, you probably had chickenpox, even if you don't recall that. That being said, regardless of your history of chickenpox, regardless of your history of having previous shingles, and you've not received the vaccine, it's a good idea to receive it.
Okay. One person typed in, I have shingles. Lesions are healed, but still have lots of pain. What can be done for the pain?
There are a number of different approaches to that chronic pain, and this is pretty classic for this thing called post-herpetic neuralgia. And I would work closely with your clinician, your caregiver in the clinic to look at options. But we have a number of things, from oral medications directed primarily at pain, to topical things that can numb the area. And I think in every case, it has to be tailored to the person in terms of what medication we use, how we apply it, how long we use it for. But that being said, we sometimes use neurologic agents. We use things occasionally. Anti-seizure medications can work. There are a whole class of different medications, but I think this is best on a one-to-one with your clinician.
Should all people in the age brackets listed receive the Shingrix vaccine regardless if they have had chickenpox or not, or were previously vaccinated for chickenpox?
And the simple answer here is yes. If you look at the recommendations out there, the recommendation is regardless of history of chickenpox, regardless of history of receiving a vaccine for chickenpox, and regardless of a prior history of shingles. And currently, even if you've had the live attenuated shingles vaccine, Zostavax, you should still get the Shingrix vaccine.
Somebody has asked for us to repeat the WIR website address. I was
and
put it in the chat, but we don't have that.
What I can do is make sure that I put the address into the handout I send off to Monona Terrace. But what I tell people, I'm terrible about remembering websites. So if you just go into Google and type in WIR, that should take you, or if you want to be more specific, if you type in Wisconsin Immunization Registry, it'll take you there. But for me, if I just type in WIR in Google, it takes me right there.
Good answer.
Nice and simple.
Can other viruses live in your system and recur? Can you have shingles virus without a rash?
Yes, there are other viruses that can take up residence and last for a long time. I'll just give you one example from recent history. In 2013-14, we had a big Ebola outbreak, and we had people who were cured of Ebola in Africa and would have recurrence. And there are areas of the body that sometimes viruses can hide out in. And this has been a problem with HIV as well. And the second part of the question, Laura?
Oh, let's see, I lost it here.
That
we'll come back to that.
Okay.
Okay. We'll go to another one. For people, if someone is immunized against polio, are they less susceptible to shingles?
Not that I know of. The polio virus is closely related to actually one of our common cold viruses. It's in a family called the enteroviruses. And shingles is a herpes virus. It's in the family. So I don't think there's any cross protection from either having polio or having the polio vaccine.
Let's see. I'm still looking for that one. I can't find it. Sorry. But I think we pretty much answered it. Let's see here. Okay. This is a real specific example. I received an infusion of Entyvio to counter colitis every 6 weeks. Do I need to adjust timing of shingles vaccine accordingly?
Yeah, so quick answer is when you're taking something that interacts with the immune system and basically something that is going to make your immune system less responsive, that when you get a vaccine at that same time, you need your immune system to respond to the vaccine. So if you're turning down the tap a little bit on the responses of your immune system, you're going to make the response to that vaccine less good. And so this is one where I think you work with the clinician you're working with who's giving the medication, be it a gastroenterologist or a oncologist, hematologist, but they can usually help with that question, especially the people who are familiar with those chemotherapy agents.
Okay. Can you get shingles virus and not have the rash?
Yeah, and that was the question from before, and yes. you sure can. With just about everything, when we look at viruses, we can see responses on a scale from 0 to 100. We saw this with, especially in our very recent memory with COVID-19, we have people who were infected that had nothing, and we had people who were infected that rapidly deteriorated, went to intensive care unit, maybe even died. And same virus, and there are just so many factors between strain in terms of the host or the person who's coming down. But the bottom line is you certainly can have chickenpox without really much of a rash or any sickness. Could you have shingles without knowing it? You probably could. And I'm going to just give you a personal example. This is now probably 4 or 5 years ago. I developed a little bit of kind of itching on my left upper arm to the side. Didn't think anything of it. Never really got any rash that I knew of. But ever since, I've had a little bit of irritation in this area that I'm pretty sure is likely to be very, very mild and almost inapparent case of shingles. And to answer your question, no, I wasn't vaccinated. That the rules have changed. And at the time, I was in the group that could, but it wasn't routinely recommended for.
Okay, if someone takes a medication that can be used to treat shingles on a daily basis to treat another condition, are they less likely to contract shingles?
Yes, they are. And so if someone's taking acyclovir, valacyclovir, or famciclovir on a daily basis for viral suppression, it does a good job of suppressing shingles as well.
Okay, and looks like we're winding down here. There's get one question here that kind of is based on a personal experience. First part of it is, can shingles be linked to the COVID vaccine? I'm not sure how that is meant as far as taking them together or one being affected by the other.
Yeah, that actually is a really interesting question, and actually came up with a former colleague of mine who got in touch with me and indicated that somebody that this person knew had received the COVID-19 vaccine, and a couple days later developed pain in the face. And the question was, well, could this be a reactivation of shingles causing the pain? And I actually got in touch with a colleague that I worked with years ago at CDC, and they went and did a very, very thorough assessment of all the data collected since the COVID-19 vaccines had come out. And the quick answer is, it appears that it may be possible that a COVID-19 vaccine could cause shingles, and subsequently that could cause nerve pain. But in their total database, their best assessment is this is exceedingly rare. So the answer is, we think it could, but does it happen very often? No, it happens incredibly rarely. And when we say incredibly rarely, we're looking at a rate maybe 1 in a million doses of vaccine.
This same person said that they had shingles in 2018, a few months after 14 months of chemo. And then they got the shingles vaccine later that year. COVID shot in 2020, and then the shingles rash showed up 6 days later. And then again, the shingles rash after the booster in 2021.
Yeah, and this is one other plug that I have, that with anything related to vaccine, if there is an occurrence of something after that vaccine that is unusual or unexpected, that anybody, you can talk to your doctor, your clinician, or you can, as a private citizen, make a report in this thing called the Vaccine Adverse Event Reporting System, or VAERS. And again, this is something, if you just Google VAERS, you get to the site. But I encourage people, patients, I encourage my colleagues, I encourage people I talk to, that if there's any concern that a vaccine could have caused something, to report that, because that's how we learn and start being alerted to the possibilities. And from the possibilities, we can start doing studies to determine whether or not there's cause and effect. But I think this is a pretty indicative case of, or a good possibility that this did occur.
Okay, this will be our last question. A friend got the old shingles vaccine a number of years ago, and as a result developed Bell's palsy. Is that possible?
Yep. And again, Bell's palsy is a inflammation in one of the facial nerves that can cause some facial paralysis. And we do know that shingles, or the varicella zoster vaccine, or the varicella zoster, or herpes zoster, can cause the palsies or the nerve paralysis. And with the live vaccine, it was a very, very, very rare event, but it could happen.
All right. Well, thank you, Dr. Temte, for the presentation. We all learned a lot today about shingles and appreciate you taking the time today. Thank you to our sponsor, All of Us Research Program. And as a reminder, a survey will be distributed within a week of our program, and your feedback is important to us. Thank you so much.
And thank you very much for your attention and your time, and have a wonderful day.